Good evening, everyone. Today, and on behalf of the study team, I will presenting our study entitled "Pattern of Trauma and Burn Injuries and Their Management Outcome in Gaza Strip: A Retrospective Cohort Analysis for the period between May 2024 and June 2025." During the period of severe health system disruption in Gaza, the focus is not only on the injury pattern but also on the short-term surgical and inpatient outcome in a functioning humanitarian trauma burn services. I will begin with the wider conflict context and why these data are important. Despite the ceasefire agreement in October 2025, violence and killing of Palestinians continue daily. The total fatalities was 72,000 and more than 172,000 injuries and more than 5,000 amputations. Hospital and rehabilitation services severely disrupted since October 7, 2023. Although 2% of all population with potential life-changing injury. Despite this, the clinical profile and conflict-related civilian injuries remain insufficiently described, which is one of the main gaps of this study aim to address. Next. In response to this systematic collapse, MSF supported of several hospitals and BICC and provision of water and sanitation. As you see in the map, here is where MSF premises located, the hospital and BICC. Today we will focus on Nasser Hospital, which highlighted in the map. MSF re-established specialized inpatient services at Nasser Medical Complex in May 2024, deploying dedicated trauma, orthopedic, and burn unit, alongside with outpatient department and microbiology. This brings us to our core operational challenges. Our specialized surgical team operated under strict triage framework, focusing on acute orthopedic trauma, complex burn, and orthoplastic reconstructive needs. However, managing these highly complex cases requires sterile continuity that was continued threatened. We faced acute shortage of specialized surgical consumable, external fixator, blood products, and vital medicine, including anesthesia and intravenous antibiotic. Despite this internal constraint, our team pushed to maintain international quality of care. Next. MSF admission criteria. MSF include patients were admitted if they presented with burn injuries, acute orthopedic trauma, orthoplastic condition, or reconstructive surgery need, either through Nasser emergency room or referred from other providers. However, the unit did not admit infant under 6 months, patient under 5 kilogram, patient require ICU level support, or patient need more urgent surgery or very high nursing workload. These criteria are important because they shape the case mix and help to explain some of the outcome we observe, particularly the mortality. Next. This was a retrospective analysis of routinely collected programmatic data. Our objective was to describe the epidemiology of trauma and burn injury among surgical inpatients admitted to the trauma orthopedic burn unit at Nasser Medical Complex. This study covered admission from May 2024 to June 2025 and focused on patient characteristics, injury mechanism, procedure, and short-term inpatient outcome. Overall, we included 3,029 patients with male prevalence and relatively small proportion under 5 years old. Trauma accounted for more than 3/4 of admission. Next. Traumatic injuries accounted for the majority of admissions and were concentrated in males, with relatively few children under 5. What stands out is the mixed mechanism profile. Explosive and road traffic injury contributed similarly large share, with stab wounds and gunshot wounds smaller but still important. Next. Burn patients were much younger, had near equal sex ratio. The dominant mechanism was domestic hot liquid injuries, which points to an important pediatric and household burn burden alongside with the conflict-related burns. This graph shows the demographic profile by age and sex distribution. This figure illustrates the age distribution within the trauma and burn cohort. The trauma group is mainly composed of adolescents and adults, especially male in young and middle adulthood. In contrast, the burn cohort is heavily concentrated in the youngest age group, especially children under 10 years old, and show more balanced sex distribution. This reinforces that trauma and burn represent two distinct epidemiological profiles requiring different prevention and care strategies. Next. The two graphs show the monthly inpatient admission at MSF Trauma Orthopedic Unit from May 2024 until to June 2025. We have two yellow dots in the two graphs. This explains when the project inception and when MSF forced to leave Nasser Hospital in June 2025. And the two lines, the one in the green when the ceasefire launched in 19th of January 25, and when the war resumed in the 18th of March in March 2025. The 14-month trend highlights the two distinctly different epidemiological patterns across the cohort, bounded by the project inception, marking the operational startup of our specialized trauma and burn response, and MSF forced close, which denote the abrupt involuntary termination of our medical services due to the critical security threat. Burn on the left side, burn admission demonstrate a flat, highly stable background rate, constantly fluctuating at low baseline between roughly 20 to 40 monthly. The timeline event have virtual no correlation with burn admission. This indicates that burn in this setting represent an ongoing domestic or environmental community health burden. Example like household accident, the cooking way, that persist independently of external geopolitical or security dynamics. On the right side graph, traumatic admission are highly violent and volume heavily surging from project inception up to a peak of over 200 monthly admission by late 2024. The trauma volume reacts strongly to security shift following the ceasefire launched in 19th of January 2025. There is a visible decompression in caseload into January and February, where when the war resumed on 18th of March, admission remained elevated, but show slightly stabilization rather than an immediate geometric spike, potentially pointing to altered hospital cases access route, displaced population, and shifting the front line away from the facility. Next. In terms of clinical management, MSF provide multidisciplinary services, inpatient services, outpatient, mental health, health education, antibiotic stewardship, occupational therapist, and physiotherapy. The mean length of stay was 14 days for burn patient and 8 for trauma patient. This is reflect the high complexity for the 14 days for burn patient, reflect the high complexity of prolonged wound management, dressing change under anesthesia, and delayed discharge due to unsafe damage or overcrowded home environments. The rapid trauma turnover driven by intense bed occupancy pressure on and mass casualties. Uniform surgical intensity, the mean was 2 for burn and traumatic injuries, demonstrate that despite the high violate patient volume, both cohorts require baseline early definitive surgery followed by mandatory and secondary washout or revision. Next. For amputation, the age 6 distribution for amputation actually, the total amputation was 130 patients, which equal 5% of our cohort. This unified population pyramid show that injury amputation heavily concentrated among young children of both sex due to the severe physiological vulnerability, but shift overwhelm toward young adults from 10 to 39 years old as a direct result of gendered exposure to blast and structural collapse in the conflict zone. I want to highlight, go back. Most of amputation that we mentioned here, it's defined as injury amputation, which defined as the complete or partial severing of a limb that happened at the sense of the incident as a direct result of kinetics, mechanical, or thermal force, blast wave, collapsing structure, or crushing injuries. These patients arrive at the triage with the limb already missing or completely unsalvageable. It's measured the immediate raw destructive power of the energy mechanism itself. Next. For the anatomical distribution of traumatic amputation, as shown, most of amputation are mostly major and proximal. We split for upper limb amputation and lower limb amputation. The lower limb amputation predominance for 63.8% is characterized of ground level of explosion, collapsing structure with direct destructive kinetics energy upward, which upper extremity are often spread or face only secondary fragmentation. This high prevalence of the lower limb loss highlight a critical long-term public health need for prosthesis and rehabilitation services. Conversely, for the upper limb amputation, which equals 36 of the cohort, most of the amputation happen in the finger and partial hands. Next. For the reconstructive procedure outcome, the result report took reconstructive surgical procedure, surgical skin graft and a flap. 13% of the cohort underwent skin graft and 4% underwent flap. Skin graft outcome were good in both burn and trauma groups. Around 4 and 5 grafts were completely taken, and outright failure was uncommon in both groups. In trauma patients, most flap were completely taken, and failure remained rare. This suggests that effective reconstructive wound care remain visible despite the challenging context. Next. For the inpatient complication, record inpatient complication were uncommon overall. Most patient has no documented complication. Among the complications that were recorded, wound and surgical complication were more frequent in trauma, while respiratory and systematic complications were relatively uncommon in both groups. These low rates should be interpreted carefully as they reflect the short-term inpatient follow-up and routine programmatic data collection. Next. For the exit outcome, the table showed the most common outcome for both cohorts was successful recovery and discharge directly home. Their patient face significantly higher risk in patient death due to the subacute systematic complication like sepsis or severe fluid loss. ICU escalation 3.74 burn patient need ICU compared to 1.1 of trauma patient. Also, the inpatient mortality, the burn patient have higher percent rather than the traumatic group. Next. For the limitation, these findings should be interpreted in light of important limitation of routine program data. The cohort exclude polytrauma and ICU patient, and we could not assess long-term disability, function, and psychological outcome. So this study is the strongest for describing inpatient pattern and short-term outcome, not the full burden of post-injury recovery. Next slide. The overall message here, more than 60% of trauma and 30% of burn cases caused by violence. Burn disproportionately affected children and trauma concentrated in adult males. Short-term hospital outcome were generally good, with low inpatient mortality, low record complication rate, and high proportion of patient discharge home. However, a high burden of amputation and severe burn and complex fracture indicate considerable unmet needs for long-term rehabilitation and reconstructive care. Next. The October 7 war differed markedly from previous MSF intervention, like the Great March of Return, with more severe injury. injuries, greater health system damage, large supply shortage, and more loss of medical staff. This finding underscored the importance of maintaining specialized surgical and rehabilitation services in a protracted conflict setting. Next. Finally, I would like to acknowledge the medical, nursing, logistic, and data team who made this work possible under extremely difficult conditions. Their commitment to patient care and documentation was essential both to service delivery and to this analysis. I also thank Epicenter and MSF colleagues for their support and collaboration. Thank you.